together to form larger vessels that we call lymphatics. And these lymphatics are going to be very similar to veins in many respects. They're going to be relatively thin-walled, and just like veins, they're going to have internal valves to only allow movement of fluid that we would call lymph in one direction. These lymphatics are going to come together to form progressively larger and larger lymphatics, all of them with these internal valves. Please keep in mind, lymphatics do not have a media layer. They have an intima, they have an adventitious, but no media layer at all. They have no muscular component at all. Eventually, these lymphatics will run into larger masses of lymphatic tissue, kind of like so. You have multiple lymphatics coming in, and typically one going out. And these larger masses of lymphatic tissue are referred to as lymph nodes, and smaller ones would be lymph nodules. Lymph nodes and lymph nodules. Lymph may pass through several of these before being reincorporated into the blood. And what they are is kind of multi-chambered masses of lymphatic tissue that will have phagocytes attached on the inner walls. These phagocytes will pull out of the lymph things like pieces of cellular debris, potential pathogens, things of this sort. And actually, within some of these lymph nodules, you get some of the specific aspects of immunity programmed. So these are going to play a role in what is known as specific immunity. Specific immunity, again, an inflammatory response, as I told you guys at the beginning of the semester when we did in taking it. An inflammatory response is a non-specific immune response. That means it's a generalized response. It's not being directed against any one particular thing. A specific immune response is a response where you generate an immune response against one single kind of item. A particular virus, a particular bacteria. Very, very highly specialized that you have just that one response for that one target item. All right, you have to program this to some degree in the system. It's part of what they call acquired immunity. These lymph nodes and lymph nodules are going to participate in that programming, developing an immunity against something. You say, well, if you develop immunities, why is it you get kind of the same thing over and over again? Well, with things like the common cold, the flu virus, things of that sort, they mutate very, very rapidly. And the body doesn't recognize it as being the same thing again. So you have to develop a whole new response to it. Put it in short form. Yeah.
So they work together to create immunity against something?
They help work together to create a specific immune response. There's more to it than this. There you get into the different kinds of lymphocytes and antibody production and memory cells and all of that kind of thing, which really kind of go beyond the scope of a course like this.
Mm-hmm.
But suffice it to say, this is at part of where a specific immune response can be generated. There are other pathways as well, but this is just one of them. Eventually, usually after going through multiple lymph nodes and or nodules, the lymph is going to be dumped back into the cardiovascular system. Now you've got to keep in mind, there's not a real pump for this. You're following a pressure gradient, and it's very, very, very low pressure system. And about the only thing that helps it along is these lymphatics as they pass either through or around skeletal muscles. As muscles contract, they compress the lymphatics, and because of those internal valves, the lymph can only be forced in one direction. So we've got a very, very low pressure system here, and we're eventually gonna dump this lymph back into the blood plasma. There are two ducts, they're called lymphatic ducts, that do this. Imaginatively enough, they're called the right and left lymphatic ducts. Specifically, as you take a look at it, the left lymphatic duct, also called the thoracic duct, essentially is going to drain lymph from the left side of the thorax, left side of the head and neck, left arm, and all of the abdomen and both legs. So by far the majority of the lymphatics in the body are going to dump into the left lymphatic or thoracic duct. The right thoracic duct, or I'm sorry, the right lymphatic duct, just drains the upper part of the right thoracic region, right head and neck, and right arm. Where do they dump the lymph back in? They do it in the subclavian veins. Typically, and those of you that haven't had lab yet, one of the things you're going to do is look at where this happens, at least on the left side. Typically, it's right in between the internal and external jugular vein on the subclavian. Why the subclavian vein? Why would that be a good place to dump lymph back in, based on what you know about circulation? No, actually, it's exactly the opposite. It's very low pressure. Veins are lower pressure than arteries, by definition. And as you get closer and closer to the heart, pressure drops more and more. Okay, so why not, like, dump it into the inferior vena cava? Okay, you spend a substantial part of your day in a more or less upright position. Yes? Inferior vena cava, blood is having to move against gravity. It actually has a little more pressure to it to get blood up into the heart when you're upright. Superior vena cava, gravity is working with it as blood drops down into the heart. With the assisted gravity then, we've got a bit lower pressure in the subclavian veins, the brachiocephalic vein, and the superior vena cava. You want a low pressure area, the lowest pressure, one of the lower pressure areas you can get, because the pressure in the lymphatic has to exceed the pressure in the blood. Otherwise, it won't be moved in. Like blood, lymph has to follow the pressure gradients. Huh?
Lymph has to follow a lower pressure gradient in order to.
If you're following a pressure gradient, you're going from high pressure to low pressure in anything.
So it goes in the subclavian, it goes through the subclavian vein because it's the lowest pressure you can get.
It's one of the lower pressure areas you can get, yes.
Okay.
It's not the lowest, but it is low enough that you can incorporate lymph in the blood.
Is it the left lymphatic duct or in the right lymphatic duct both go to the subclavian?
Yes,
Okay.
on their respective sides. Okay, lymphatic system is going to be involved in draining excess interstitial fluid. It's going to be involved in specific immune responses. It has a few organs, a few larger organs like the tonsils and the spleen, and the thymus is considered a lymphatic organ as well as the endocrine organ. Tonsils and spleen, or I'm sorry, the tonsils primarily are involved in generating immune responses. The spleen, in addition to that, also acts as kind of a blood reservoir. It's very, very highly vascularized. And it's one of the places in the body that we break down worn out red blood cells. So it's a lymphatic structure that also has some cardiovascular function to it. Lymphatics are gonna be used to transport nutrients, interestingly enough. Non-water soluble nutrients absorbed by way of the intestines. A lot of them are picked up not by the blood directly, but by the lymphatics in the intestines. And don't get incorporated into the blood until they're dumped into the subclavian veins. So nutrient transport then also becomes a function of the lymphatic system. So, it's a system in here, in lab, you're not gonna look at a lot of structures on because we just don't have a lot for you to see in there. And when you get into microbiology, certainly we'll talk about this a whole lot more, and to a lesser extent, physiology. But it kind of gives you an idea. It's a bit broader base than just dealing with immunity here. All right? So, just a kind of quickie overview. This is why I didn't have you reread the chapter on lymphatic system. Yes, sir?
Okay, you said low pressure in the lymph, or in the lymph vessels,
Yeah, they're all very low pressure vessels.
right? So muscle contraction actually helps the movement of the lymph?
Huh?
So does that mean that muscle tone would increase immunity?
Not necessarily, no. It would certainly speed up a movement through the lymphatic system, yes.
Okay.
But, and, you know, for that reason, if you stop and think about it, people with good muscle tone, you start thinking about edemic events, swelling events, they don't usually have that much trouble with things like their feet swelling
Right.
and all of that. They're moving lymph through the system more rapidly. I have not seen a direct tie-in with rate of movement of lymph through the lymphatics and bolstering immune response. There may be one, but I have not seen any data.
Thank you.
So, sorry, I can't give you a more definitive answer on that. All right. Now, what you guys did read about for today was respiratory system. So let's talk a little bit about respiratory system. You guys can take a look at their case as it moves through the lungs. There's a few things about respiratory system you guys need to be aware of before we get into that. First off, in respiratory system, get rid of some of this. Couple of terms. Inspiration. And expiration. Inspiration, is that what you were hoping for on the quiz? And expiration is what happened if inspiration didn't work on the quiz, yes? Inspiration is the formal term for the act of inhaling. Expiration is the act of exhaling. Now, gang, one of the things you have to be aware of in the way this kind of process works in the human body is that we draw air into our lungs by way of what would be called a negative pressure system. You literally suck air into your lungs. And you might think, well, that makes sense. That's the way anything with lungs would work. No, it's really not. If you look at something like, say, a frog, you know, you see underneath the chin on a frog, it looks like the chin's constantly bobbing. It's because they're pushing air into their lungs. They're using positive pressure. We use negative pressure. To use negative pressure, what that basically boils down to is to get the lungs to expand. The lungs themselves really don't have any muscles that do this. They rely on pressure changes in the thoracic cavity that they respond to. If we decrease pressure in the thoracic cavity, that causes the lungs to expand. Holes on the outside of the lungs, causing them to stretch, causing pressure in the lungs to drop, which causes air to be drawn in through either the nostrils or the oral cavity. Now, that's how inspiration occurs. Now, how do we increase volume in the thoracic cavity? In order to do this, those of you that have to take physiology, you don't have to know this right now, but in physiology, you start playing games with not just chemistry and anatomy, but with physics as well. And there is a gas law that we call Boyle's law that says if you have a set amount of, say, a gas, and you increase the volume, pressure decreases. You decrease the volume, pressure increases. It's going to work that way in the thoracic cavity. We have to increase the volume to get the pressure to drop so air can be drawn in. Next time you're in lab, look at the articulated skeletons in the back of the room. Look at them from a lateral view. You're going to see the ribs in the rib cage in a relaxed position, going from posterior to anterior. They're going to angle slightly downward. Now, contrary to what most people think, you guys know better because you've looked at ribs. Ribs are not real springy. They don't bend a lot. In fact, they hardly bend at all. If we raise the sternum, elevate the sternum, the curvature of the ribs isn't going to change. What we're going to do instead is have the ribs move outward. It's kind of like, if you've got a bucket laying on its side, and it's got one of those hinged handles on it. If you raise the hinge, it moves further and further, you raise the handle, the outer part of the curve moves further and further away from the bucket. You're not changing the curvature on the handle, it's all remaining absolutely rigid. You're just changing its position with respect to the bucket. Got the same kind of thing happening when you elevate your ribs. Thinking back to the lab practical before last, when you guys did your very favorite thing, you did muscles. Y'all remember the external intercostal muscles? What was the action of those muscles? Oh, you see, you thought all of that went away, didn't you? It didn't. It's back. Elevate which rib? It's between the ribs. So what rib is it going to elevate? It's attached to two. Huh?
The one underneath it.
The one below, the one with the lower point of attachment. It's going to pull that one up. But you've got these at multiple levels, so the overall effect is you're elevating the whole rib cage. And as you do, the sternum moves out, the volume in the thoracic cavity increases. That would be one of your primary inspiratory muscles. It's used to increase volume of the thoracic cavity. Another primary inspiratory muscle would be one that I didn't have you do when we did muscular system, but it's one that they talk about in this chapter, the diaphragm. Now you guys looked at the diaphragm last time. It's kind of the boundary between thoracic and abdominal cavities, and you notice it kind of bulges up into the thoracic cavity a little bit. It's attached to the ribs and the vertebral column around the perimeter. When that muscle contracts, it pulls on a central tendon, and it does a number like this. It flattens out. That means the floor of the thoracic cavity drops, again increasing the volume. So it's another major inspiratory muscle. This allows you to draw air in, undergo inspiration. At rest, like you guys are now, expiration, that's pretty easy. You just relax those muscles. When you relax the external intercostals, the ribs drop. Gravity's going to pull them down. Volume in the thoracic cavity decreases, more more pressure is applied to the lungs. When pressure in the lungs exceeds outside air pressure, air is forced out. Expiration occurs. Inspiration, expiration. Hey, they're not that bad when you think about the way the mechanics work. But here, we have to take and combine aspects of the muscular system and the skeletal system to explain what's going on in the respiratory system. Now, we're at that point in the semester where lots of different things are going to start meshing, coming together. You're going to have to start thinking a little bit in nonlinear fashions. By that, I mean you need to start thinking a little bit kind of in webs. Now we're going to start relating bunches of different things together. This is good practice, especially those of you that have to take physiology later on, because that's mostly what physiology deals with. You're going to be connecting all different kinds of things together to figure out how the body works overall. This is just a small example of it. All right? So, now we have a mechanism for inspiration and expiration. Let's take and put that to work then, and see how the respiratory system is going to work. Now, gang, for some of the finer, there we go. For some of the finer detail, in one of the other lecture rooms, the remote wasn't working for a while. So I still managed to get the machine turned on by the remote. I found it standing, if I reached up with the remote, I could hit the on button on the machine. With that in mind, as far as mechanisms for inspiration and expiration, keep in mind, those of you that haven't had lab, there's some anatomical details that we're not going to go over down here that we will go over upstairs in the laboratory. So, you know, if you feel cheated on detail, don't worry, we will cover it upstairs. As we look at respiratory system, there are several points that we need to consider. You guys, and why is that on there? Go away. You guys, for today, trace the flow that air takes. There's two different pathways air can take. Go in through the oral cavity or through the nasal cavity. In the vast majority of cases, it's going to go in through the nasal cavity. Here, through openings that we call the external nares. And as it passes through the nasal cavity, gang, several things are going to have to happen to it. As I pointed out to the people that had lab earlier this morning, the air you're currently breathing is not suitable for the lungs. First, it's too cold. The air in this room is at least 20 degrees too cold. Keep in mind, when you guys read about this, gas exchange between blood and the outside environment occurs specifically where? What? In the alveoli. The walls of the alveoli are made up of simple squamous epithelium. Okay, that being the case, the air being too cold is going to be a real problem. We've got to heat it up. We've got to warm the air up to around core body temperature, which is about 98.6 degrees Fahrenheit. And the air is too dry that you're currently breathing. In this room, you're looking at somewhere between 30 and 40% relative humidity. We need to get that up near 100% because we don't want to dry those tissues out. They're too delicate. So we're going to heat the air up and we're going to humidify the air. And in the process, we're also going to filter out some of the particulates in the air. Now, the way we're going to take and accomplish all this is all done during each inspiration. The way we're going to take and accomplish this is by way of the respiratory epithelium. Thinking back to when we did histology, you guys looked at slides of epithelium from the nasal cavity, and it was pseudostratified columnar epithelium, and it was ciliated. Got lots of goblet cells. Goblet cells are producing mucus. That's what they functionally do. These goblet cells are continually producing mucus, and you've got a mucus flow that's going to be generated by the cilia. This occurs in the nasal cavity and in most aspects of the upper respiratory system. The mucus serves multiple purposes. It keeps the living tissues moist. It's because it's kind of tacky in nature, it's going to help pull particulates out of the air. Any particulates that get, come in contact with the mucus get stuck to it.
It pulls what?
Particulates out of the air. And because mucus is mainly water by composition, as water evaporates out of the mucus, it helps humidify the air. So, the epithelium here is going to play some pretty major roles. Now, you're constantly producing this, and like everything else, if it's being constantly produced, it must go somewhere. Mucus being produced by epithelium in the nasal cavity is going to pass back through what we call the nasopharynx, and eventually down into the esophagus and pass through the digestive system. So you're constantly generating this mucus, and quite literally you're constantly swallowing it, along with any particulates that have been pulled out of the air. This is something that goes on 24 hours a day, 7 days a week. All right, we've got the same kind of epithelium lining the trachea here and the branchings of the trachea, the primary bronchi going into all of the smaller branches of the bronchi. You have that same kind of arrangement going on, but here, mucus, as you remember from back when we talked about this in histology, the cilia are moving the mucus upward against the pull of gravity, and again, we're going to dump it down the esophagus and into the digestive system. So you've got this constant flow of mucus going on, very thin layer of mucus over these living tissues. That's helping filter particulates out of the air and helping humidify the air. Deep to this simple epithelium, we call pseudostratified columnar epithelium, you're going to have lots of capillary beds. Very, very highly vascularized area just immediately deep to this epithelium. The blood vessels here, you're not having gas exchange occur with these blood vessels, but rather those blood vessels are being used to heat the air up to something near core body temperature. And this all occurs really very, very quickly. In a matter of seconds, you have all of this happening. All right. So, as we move, on down through this system, air is going to pass through a cartilaginous structure that we call the larynx. And that is, as I pointed out to the earlier lab section, larynx, not larynx. When you say something like larynx to anybody that's a biology person or anybody that's in the healthcare field, it's like saying, I ain't got no problem with terminology. You're basically sounding kind of semi-illiterate. Larynx, like skating rinks, one of the most mispronounced words in anatomical nomenclature. Larynx is a cartilaginous structure made up of hyaline cartilage. Now we're going to essentially take and funnel air through this into the trachea. Now the trachea, you notice, has cartilaginous rings, and in between those cartilaginous rings you've got ligaments to call annular ligaments. Question, based on what you currently know about how respiration works, how breathing works, why do we need these cartilaginous rings? Pardon? Okay, you're on the right track, just take it a little further. Well, it really doesn't expand though. Now,
When
taking air into the lungs. If this tube isn't fairly rigid, it's gonna collapse. When you guys get done with class today, you are gonna be right around lunchtime and decide, oh, you know, I feel an intense need for pseudo food. And they just installed a McDonald's just like right next door to us. So you go through the drive-thru at McDonald's and you get, because you're dieting, one of their 3-quart chocolate shakes, which is really not much more than soft serve ice cream dumped in a glass. And they put sadistically, they put a straw in there and hand it to you. Like you're really gonna be able to draw that ice cream up through the straw in the condition it's in. You suck on the straw, and you suck on the straw, and you suck on the straw, and eventually the straw collapses. And once it collapses, you're done. You're not gonna get anything through it. You wouldn't be able to get water through it. Yeah? So we need a fairly rigid tube here. Why have these annular ligaments in between the cartilaginous rings? Why not then just have the trachea be a solid piece of cartilage? Yeah! Gang! With solid cartilage, you wouldn't be able to do that. Yeah? You lose flexibility. So we need rings with ligaments in between them to allow this tube to be somewhat rigid but still flexible. Got to strike a balance here. Now, the other thing we see in these cartilaginous rings, and you can see this from these illustrations, is that each cartilaginous ring is going to be organized kind of like this. We're looking at it from like a superior view, where this would be anterior, this would be posterior. We have our hyaline cartilage ring, but it's actually kind of C-shaped. And going then across the posterior aspect, the opening of the C, we're going to have some dense connective tissue here, and a little bit of muscular tissue. Why not have this a complete ring? Why have it instead this C-shaped ring we see here when we look at it from above?
Looks like the small things allows it to change shape to make things through.
Okay, good. Immediately posterior to the trachea, you have a collapsed muscular tube here that is the esophagus. That's basically what connects your mouth to your stomach. When you swallow something, the esophagus is going to stretch. Well, it's pressed right up against the trachea here, gang. If the esophagus stretches, pressing up against a rigid structure, that's going to limit the degree to which it can be stretched by a bolus of food or mass of food. That would limit the size of a mass of food that you can swallow. By having the posterior side of the trachea essentially open, with just connective tissue and muscle connecting the pieces, when the esophagus stretches, it can cause this to bulge inward a little bit without really interfering with the airway. It may bulge inward a little bit, but it's not going to block off this big opening here. So, it facilitates swallowing. Okay, good. You guys are thinking about this stuff. Now, as air is then drawn through the trachea into the bronchi, go ahead and put the bronchial tree up there. As air is drawn in through the trachea into the bronchi, bronchi are going to branch into primary branches, then secondary, then tertiary, and they continue branching into progressively smaller and smaller branchings. Take note, we have these cartilaginous rings on all of these, up to a point. Now, something you're not gonna see in the lab, but that I want you to be aware of, is this. As our branchings get progressively smaller and smaller, we start seeing less and less cartilage, until we get down to the level of almost microscopic branchings that they call bronchioles. These bronchioles, you know, there's no blue on them. Yes? No cartilage. Bronchioles have a smooth muscle component to their wall. The smooth muscle here is single unit smooth muscle. And because they're so small in size, the relatively thick smooth muscle of the wall provides enough rigidity to keep them from collapsing. For the most part, we have the capacity to modify how easy it is to get air in and out of the lungs. We can increase or decrease resistance to the airflow. That's done at the level of the bronchioles. They're the only part of this system that is flexible enough that we can constrict them or allow them to dilate to change how easily air flows through this. So when we modify airflow in the lungs, we're going to do this at the level of the bronchioles. Now, like the bronchi, bronchioles are going to have primary, secondary, tertiary branchings, going all the way down eventually to respiratory bronchioles. And then the respiratory bronchioles are going to have branching off of them, or coming off of them, lobules, where the capillary, or I'm sorry, where the alveoli are going to be. Now, before we get into the alveoli here, these bronchioles, sometimes people run into problems with bronchioles. If something causes the bronchioles to constrict too much, it makes it hard to breathe. It makes it hard to inhale or exhale, either one. Because when they become too constricted, it impedes the airflow. See this in people that are suffering from bronchitis, which is an inflammation of the bronchioles, or people that have chronic disorders like asthma run into this periodically. You know, you remember back when we talked about aspects of autonomic nervous system? Interesting thing, under sympathetic stimulation, bronchioles dilate. And that kind of makes sense, because if you get into a fight or flight mode, you want air moving as easily through the lungs as possible. What causes the bronchioles to dilate is a neurotransmitter like norepinephrine or epinephrine that inhibits contraction. It doesn't cause some kind of muscular movement that forces them to dilate. It just inhibits contraction in that smooth muscle. It's circular smooth muscle. So if we inhibit contraction, the muscles rebound to their original length, and the diameter of the tube increases. If you go and get an inhaler or a bronchodilator, there's all kinds of different materials they use, but one of the simpler ones would be an epinephrine inhaler. You get those over the counter. That causes this bronchodilation to occur so you breathe easier in instances where these become spasmodically contracted. We're artificially generating a sympathetic response. Tell me something. From a clinical standpoint, are there any side effects you can think of that might generate? We've talked about epinephrine, at least briefly. Epinephrine is produced where? There's a gland that produces it. What is it? Suprarenal glands, yeah. And when it's released into the bloodstream, everything that has receptors for sympathetic nervous system gets directly stimulated. Oh. So this stuff, if it diffuses into the blood, say by way of the alveoli, would you not expect some kind of a generalized sympathetic response? Slight dilation of the pupils, increase in heart rate, things like that. And yeah, that's one of the side effects of this particular kind of inhaler. Has the effect of dilating the bronchioles, but if you're using epinephrine as the active agent, it's being done in very low dosages. But even so, you get something almost like a fight or flight response that gets developed, or that develops, because you're getting epinephrine generally released into the bloodstream. The effect is usually fairly short term. But it's one of those things where here again, now we're getting endocrine system and autonomic nervous system tied in with respiratory system here in regulating airflow, both during inspiration and expiration. All right, let's take this down further to an even more microscopic level. When we look at these lobules magnified, what we're going to see is something kind of like this. Okay, several different features here. This is the outside of the lung. Take note, we have two layers of membrane around the outside of the lung. This is just like it was in the heart, yes? We have a visceral pleura and we have a parietal pleura. Visceral pleura is in contact with the surface of the lung. Parietal pleura is in contact with the inner wall of the thoracic cavity. In between these, again, just like in the heart, we have fluid. Very, very thin layer of fluid, they refer to as a pleural fluid. It does much the same thing as the fluid in the pericardial sac does. It acts mainly as a lubricant. As these lungs are being expanded and contracted pretty much continuously, chance of friction building up is pretty substantial, so we want to reduce friction as much as possible. You know, if, say, you get a real bad cold or upper respiratory infection of some variety, and I don't know why they keep popping up, you're coughing hard and you're coughing a lot over a long period of time. One of the things that can happen is these pleural membranes can become inflamed. As they become inflamed, every time you inhale and exhale, they rub. Okay, that increases friction, which causes more inflammation, which stimulates nociceptors. The result is something that they call pleurisy. And pleurisy, any of you who have been unfortunate enough to ever experience that, pleurisy is something that is incredibly uncomfortable. It's very, very painful. Every single breath you take, you get this stabbing pain with it because of this increase in friction. So the whole friction reduction thing here is absolutely essential for normal function. The other thing, most people, and you guys having read this chapter know better, but the vast majority of people out there in the world, when they think of the lungs, they think of each lung as being essentially a big bag filled with air. And that's not the case. As you look at this, you see that instead of being a big sac, we've got a whole bunch of tiny little sacs that we call alveoli. Advantage to this would be
Surface area.
that's you guys are smart.
Surface area.
What about it?
Surface area.
What about it?
Increase it.
Increase the surface area. You can't just say surface area. You gotta say what you're doing with it.
More.
Increase the surface area. Gang, if each lung was essentially one single big sac, or even the lobes of the lungs were individual sacs, if I were to take then a normal adult set of human lungs and open them up, they were each one a big sac, I could open them up, spread them out flat, and pretty much cover this instructor's desk from that end to maybe about here. And you say, well, that's a pretty big area to have stuffed inside your thoracic cavity. But it's not nearly enough. If I were to take every single alveolus normal adult set of human lungs. It's just typical adult human lungs, assuming they're healthy human lungs. And cut it open and laid it out flat and put them all edge to edge. I could cover a standard single tennis court. You have that much gas exchange area, yes.
So whenever people have smoker lungs, they don't have as many alveoli, or
When they have what?
they don't have as much of alveoli, or
If what?
if they have what's known as smoker lungs, or like damage.
Well, no, it depends. Smoker's lungs covers a lot of ground.
Okay.
Lots of different things happen to damage the lungs in smoking. Damage the cilia and all of that, as we talked about earlier in the semester, causing fluid buildup, which doesn't decrease surface area, it just means you don't have the direct gas exchange occurring. In emphysema reduces the surface area. And, start out with alveoli. We have an alveolar duct here leading into a series of alveoli. All right, this would be the normal configuration, and you notice when you look at the alveoli, see the pulmonary capillaries completely surrounding those. Highly, highly vascularized structure. These reddish bands you're seeing here are bundles of elastic fibers, not muscle. The alveoli have no muscular component to them at all. They're just passively responding to pressure changes around them. All right, with all these alveoli, then we have immense surface area. If you're constantly irritating the lungs with something, cigarette smoke's one of the more common ways of going about this. One of the things that can happen is an irreversible, at least with current medical knowledge, condition where we get something like this happen. The alveoli start fusing. Now, we have a much bigger bag, but less surface area to work with. In emphysema, this is what happens. Now, in many cases, if you stop whatever the irritant is, you can stop the progression of the disorder, but you can't reverse it. It's not going to get any better, but it won't get any worse. I have seen people whose lungs were so compromised by this disorder that they were on constant supplemental oxygen. So they're wheeling oxygen around with them everywhere they go, and still puffing away on the cigarettes. Quite frankly, the inherent stupidity involved in that, not only are you a major fire hazard at that point, because you're dealing with pure oxygen and fire in the same place. Fine concept. But you're on oxygen because you've fused a bunch of alveoli in your lungs, and you're continually making the process or the problem worse. So that you become more and more oxygen dependent. Gang, ordinarily you cannot survive long-term pure oxygen environments. If your lungs are functioning normally, pure oxygen environment will kill you over time. You die of oxygen toxicity. Oxygen is a very strong oxidizer, where the term oxidation comes from. And that being the case, in a pure oxygen environment, we're just not set up to handle that. The air you're breathing right now is somewhere between 20 and 21% oxygen by composition. About 70% of what you're breathing is nitrogen gas. All right? When they put people on pure oxygen, it's because their lungs are, for whatever reason, so compromised that, at least for any kind of long term, that it's the only way to get enough oxygen in the blood to survive, supply the tissues. All right, I know there's some physical characteristics then of these alveoli that we need to be thinking about. These would include elastance, and compliance. Compliance is how easy do these alveoli stretch. Deals with how stretchable the alveoli are, how readily can we get them to stretch out as pressure drops around them. If I take a look at the inside of an alveolus magnified. All right, gang. We've got two kinds of pneumocytes cells, simple squamous epithelial cells forming the wall of the alveolus. Got a type 1 pneumocyte, and that is just basic simple squamous epithelium here. And a type 2 pneumocyte, which, oh, okay, there's a label over there, would be one of these, that is a secretory cell. Our type 2 pneumocytes secrete materials that they call